So I'm excited. Today we're have the two authors of the journal article that we're discussing that was in the most recent Journal of Addictions Nursing. The article is the relationship between trauma and substance use among healthcare workers. And our two authors, the first is Dr. Okoli. Dr. Okoli serves as a professor at the University of Kentucky College of Nursing. He directs a number of programs, including the behavioral health and wellness environments for living and learning. And he is involved with tobacco treatment, behavioral services, and addictions. Most recently, he completed his board certification as a psych mental health nurse practitioner and is inducted in the Fellow of American Academy of Nursing. Congratulations. And there's a lot in his resume. I'm just giving you some of the highlights. He is currently the president of the American Psychiatric Nurses Association. So thank you for coming and joining. I know you have a very busy schedule, and you've made time for us is wonderful.
Thank you.
And one of his mentees is the second author, Saret Sang. She's a PhD student, getting closer by the minute. She has been involved. She's a pre-doctoral fellow with University. I'm sorry, there's some noise in the background. I don't know if it's me. So if everybody could just mute their microphones. Thank you. That makes it a little bit easier. She's a pre-doctoral fellow in the University of Kentucky's Unite program, United in True Racial Equity program, which I would love to know more about, but I'm not sure we'll get to it today. But if we did, it sounds great. And she's a student with the Center for Clinical and Translational Studies. She is part of the graduate research. She's a graduate research assistant working with Dr. Okoli in that capacity. Her research interests include substance use and interventions that support metacognitive ability, and she is currently serving as the president-elect of the Kentucky chapter of APNA. So I feel very honored to have both of you here. They've decided to start by reviewing the research with a PowerPoint, which is just going to guide their discussion, and then we'll be free to have an open discussion of our own. So, Sarah, do you need any help?
No, let me just get it set up and I'll get started. I need to move some Zoom things out of the way. And presenter view. Okay, can you all see this portion, the slides on the screen?
I can.
Okay. So we're just going to give a brief overview of this presentation about the paper. And again, it's the relationship between trauma and substance use among healthcare workers. So just a bit of background on this subject. Healthcare workers are uniquely vulnerable to occupational trauma exposure due to the responsibility of caring for people in diverse settings. For example, they may feel vicarious trauma from caring for patients with severe injuries, or even just hearing about the ways that the patients were victimized or how they got those injuries. They may experience trauma that way. They may experience direct trauma from patient threats or violence, or endure workplace violence from dysfunctional leadership or bullying and harassment from coworkers. And a well-established consequence among individuals experiencing trauma is maladaptive coping through substance use. Two of the most abused legal substances, tobacco and alcohol, have been linked to various detrimental health outcomes, including cardiovascular and respiratory illnesses and greater rates of cancer. So in addition to the negative consequences on health outcomes, substance use among healthcare workers in particular is especially concerning due to its detrimental effect on job-related duties. So although several studies have linked tobacco and alcohol use to traumatic experiences, few studies have examined substance use prevalence associated with trauma exposure among healthcare workers. So the purpose of this study was to examine the following among a sample of healthcare workers at an academic medical center. First, we want to look at the frequency of current tobacco use and risky alcohol use. the frequency and types of traumatic experiences, and the associations between frequency of trauma experiences and current tobacco use and risky alcohol use while controlling for various factors. So this study was a secondary analysis of data collected from 850 healthcare workers at a large academic medical center in Kentucky. We collected responses to a voluntary and anonymous 10-minute electronic survey. We emailed potential participants through email listservs associated with their institutions. And we had the survey open from November 2018 to April 2019. We performed multivariate logistic regression analyses to assess factors that are associated with tobacco use and risky alcohol use. And we controlled for demographic, work-related, and behavioral and lifestyle variables. On the right-hand side, these were the measures that we used. We collected information on demographics, job role, trauma experiences, whether the participants had ever received counseling or medications as part of trauma treatment, and we asked about their substance use. And to elaborate further on the substance use outcomes, first, to determine if participants were a current tobacco user, we asked them, have you used any tobacco products in the past 30 days? And this question is a validated measure of current tobacco use based on the data from Substance Use and Mental Health Services Administration. And then to assess risky alcohol use, we asked a combination of 3 questions about when was the last time they used alcohol, how many standard drinks containing alcohol they have on a typical day, and how often they have 6 or more drinks on one occasion. And to be considered a risky alcohol users, those who selected these particular pattern choices were coded as either risky alcohol use, and those who selected lesser options were non-risky alcohol users. So the majority of our sample were female, less than 36 years of age. They were married or widowed and had a college degree or higher. Almost a quarter of participants had ever received trauma treatments. And we identified that there were 11.5% of our participants who were current tobacco users and 11.6% were risky alcohol users. And figure 1 shows the percentage of current tobacco use and risky alcohol use by number of trauma experiences. And so initial chi-square analyses indicated that there were significant associations between being a current tobacco user or a risky alcohol user and having a greater number of trauma experiences. And figure 2 shows the percentage of current tobacco and risky alcohol users compared to the total sample by different categories of trauma experiences. And we found that there were nearly 3/4 of the sample which reported at least one traumatic experience, with the most commonly reported being work-related violence and the least commonly reported trauma being war or terrorism. Among the current tobacco users, we saw that there were a significantly greater proportion who reported workplace violence, sexual or physical violence, serious personal injury, and domestic violence versus non-users. And among those who were considered risky alcohol users, a significantly greater proportion reported sexual or physical violence and domestic violence as compared to those that weren't considered risky alcohol users. And finally, table 1 shows the results of our multivariate logistic regression analyses, which examine the association between number of traumatic experiences and the risk for current tobacco use and risky alcohol use. So while controlling for age, gender, marital status, education, and trauma treatment, we found a dose-response relationship in which a greater number of trauma experiences were associated with greater current tobacco and risky alcohol use. So when examining current tobacco use, those who've had 2 to 3 traumatic experiences or 4 or greater were 2 times significantly more likely to be a current tobacco user as compared to those without any traumatic experiences. And when examining risky alcohol use, those who had 4 or greater traumatic experiences were 2 times significantly more likely to report risky alcohol use as compared to those who did not report any traumatic experiences. So as for discussions, implications for practice, examining associations between trauma experience and substance use is useful for incorporating trauma and substance use screening tools and treatments. And such trauma and substance use informed screening tools can be used by healthcare employers to identify at-risk individuals and offer appropriate support, such as counseling. And then for implications for research, future studies may target interventions which improve screening and treatments of trauma and substance use to support job performance and behavioral health outcomes among healthcare workers. And these are our references. Okay. So Dr. Shell, do you want me to lead this this PowerPoint up while we go about the discussion, or?
Dr. Shell, I think you're muted.
Oh.
Thank you for that. I would suggest taking it down just so we can see each other as the conversation goes on. And I agree with you, Kathy. That was a wonderful summary. So this is now the open section of the meeting, and I would welcome other people to start talking about whatever resonated with you as you listened to the presentation or you read the article. I know for me, there were a number of key points that I thought were interesting, including your number of 46% of clinical nurses who experienced workplace violence. A number. Did that surprise anybody else? Kathy, I know you taught on this.
Yeah, I just put a chat in the box that before I retired, I taught a violence prevention course for nurses, violence prevention from a public health perspective. And these results are entirely consistent with high rates of workplace violence for nurses everywhere, and it's one of the top priorities of the American Nurses Association to create safer environments for nurses.
Sorry, I'm trying to look at what's going on with the chat, and I think I'm missing some key. Oh, here we go. John, you had a question. I'm not sure if you're still here. Do you want to ask it directly and see what kind of feedback you get? So John Furman asked the question, any thoughts on why the decrease in participation in regulatory nurse monitoring programs? Not sure where that information comes from, so I'm sorry I can't provide more information either. Okay. So you're saying, Kathy, that that's a number that seems like it's a relevant number. So has this idea of correlating trauma with substance use been explored anyplace else that you're aware of, Kathy?
It's widely correlated in the literature for our patients, but this article I think is unique and innovative in that it's addressing the correlation between these factors and healthcare providers, including nurses. But a question that I had the first time I read it was in the abstract, it says it's important to screen for trauma and provide appropriate treatment resources to healthcare providers. And I was wondering if, and then later in the article, they talk about the stigma of addiction and substance use being a stigmatized behavior. And there's job fear for revealing one's substance use among healthcare providers in particular. And nurses take the greater brunt of that because physicians who use substances are more likely to have hospital support, confidentiality of their condition, better lawyers, more legal expenses, and can afford better treatment. And so when nurses get identified as being a substance user, they tend to be more likely to experience some of the criminal charges or the disciplinary charges, the criminal charge of stealing from the hospital, the substance, and the disciplinary actions against their their nursing licenses than physicians are. So I wondered if the authors were suggesting, how do they suggest screening healthcare workers for trauma? I would think that it might do better as a self-reported, self-administered survey where people could feel comfortable coming forth if they had a problem. Because a lot of hospitals, if you come forth with a problem, you might end up facing some disciplinary sanctions, but you might not be in as much hot water if you self-reveal before you get detected or before there's risk of patient harm. So that's what some of my questions were, how it would possibly, I know it says future research about this is important, and I'm so glad you brought the subject up, but I was wondering if they had any ideas about how screening healthcare professionals would be conducted, given the regulatory and stigma related issues that particularly impact nurses.
Well, thank you, Dr. Fornelli, for that question, and also the contextualization of the stigma, the challenge. Part of my background, and I'll explain some of where this comes from. The dates of our recruitment were pre-COVID. So we started this work, and it included a survey that was also looking at compassion fatigue, compassion satisfaction, secondary traumatic stress. It was a very comprehensive survey. And our idea was to understand the wellness among our healthcare providers within our academic medical center, which consists of 4 different hospitals. And I'm a psychiatric nurse right out of nursing school. Been a psych nurse ever since, over 20 years. And I worked at one of the oldest psychiatric institutions in the United States, Eastern State Hospital. It was established in 1827. And I remember...
In Virginia?
No,
Yeah.
not the Virginia one, not the Virginia one. We have this, I say the second. We think it's the first, but Virginia claims to be the first. So we'll go for second. That's okay. But I remember one time, and this may be some of your experiences, those of you who've worked psych or ER or ICU, it was shift change. And one of our patients, I worked on we call it the TOPS unit. It was the high security unit for the patients who were not appropriate to be in other units with other patients. And shift change, I was taking report in one of the rooms. I had another mental health associate with me. I was the charge at the time. And then I heard a patient come up to the station and says, "Can I ask you a question?" And then I glanced and I saw the mental health associate stand up to listen and got hit. So she ran into the report room. I ran out to see what's going on. She locked the door behind. And the patient climbed up on top of the nursing station and then jumped and kicked me in the head. And so I was watching him and he was watching me. He picked up a chair. I ran out of the nursing station. He threw chairs at me. The whole fiasco lasted probably something like 10 minutes. And then she had called for help. You hear the people running in, and then the patient looks at me. He goes right to his room, lays down, because the procedure is that he would get restrained. and possibly medicated. So this patient was not in psychosis. He had a personality disorder, antisocial. And after the incident, as the nurse, I had to debrief with him. And I asked him, I remember saying, there are constructive and not constructive ways of expressing anger. So explain to me what was going through your mind. And he said, aren't you going to sue me? I'd rather be in prison than here. So everything had been premeditated. And of course, after the process, we, as nurses, we still want to keep a safe environment for our patients. But I had nightmares for 5 years after that encounter. And you would think as a psych nurse, I would know what PTSD was. And it never registered that it was happening to me. So I had sleep problems, insomnia, never drank on the job, but did use more alcohol than usual to help me sleep. So again, I was self-medicating. So Dr. Fornelli, my long-winded answer, basically, I want to set the stage to explain that I do believe we need to learn to destigmatize substance use disorders. They're very common. One of the questions in the chat was whether we would look at methamphetamine, marijuana, opiates. We could, but why we chose tobacco and alcohol is because they are legal. The other substances in the chat request, they are not legal. And we don't know how forthcoming providers would be that they're using illegal substances. So alcohol is legal, tobacco is legal. And it's important, I believe, that we start screening for trauma. The reason we're not is because of the challenge of the ramifications. If somebody's using a substance, they could lose their job, etc. Well, that's discriminatory towards an individual who has a substance use disorder. And I think there should be an understanding in hospitals. You cannot discriminate, regardless of whether they're a worker or not. And there are legal ramifications for discriminating. And that can change the idea of the acceptability of screening. I think screening should be context within wellness. And one model of doing such screenings is in UC Davis, California. They do certain screenings for depressive disorder and also suicide risk among nurses. And they've done it with physicians. They use a third party who is separate from their hospital system to do these screenings. And once people are screened and identified, they are referred to treatment. So there are models where we can have those sort of screenings done and available to the worker. And at least they know I have a substance use disorder. It's a treatable condition. There is help. I should seek help. My workplace supports me seeking help. The same thing with trauma. I've experienced trauma. It would have helped me so much as a young nurse to have gone through some form of trauma treatment. So those are just some of my thoughts in response to your question.
And like
Hey.
you said, that was
Sorry.
before COVID, because COVID just traumatized nurses immensely at a
Exactly.
much greater degree.
Hi, everyone. My name is Shakita Carr. I'm a DMP student at Loyola University Chicago, PMHMP with a substance abuse specialty. I guess a little about me too is I'm a little nervous, sorry, but I am a nurse in recovery. I did have like disciplinary action for alcohol use. And right now I'm doing a needs assessment for, health nurses with substance abuse disorder and the need to recognize it. But I'm in my needs assessment, it's like parts 1 and parts 2. So my parts 2 right now is like interventions for recognizing. So my question 2, like Catherine, was the screening. So I know that we need the screening. With my literature review, I haven't found much interventions for like recognizing, like, of course, there's a need to recognize this in nurses, but I'm like I just can't find any research for like, well, how do we do that? So my project's due May 1st. And when this Zoom came up, I was like, wow, this is amazing. As far as the study that we're discussing, I wasn't surprised with the risk factors for alcohol use. In my childhood, I was sexually abused by 2 of my family members. But I wonder, like, how could anybody have caught that in me? I know that it's about self-reporting, but the stigma, the fear of discipline, and just someone said that nursing students should be taught that, like, before exiting nursing school, about self-reporting, just even like the care, counseling, and treatment agreements, because I had no idea about that. Once you're deep into an addiction, you're not thinking about, you just don't think of like, how can I get out of this the proper way? So yes, I have a discipline on my nursing license forever. But I guess if I knew about self-reporting, it could have been more confidential. Now, do I care about, I do care a little bit that I do have the discipline on my license forever, but I guess I just, my DMP project will be on nurses and substance abuse. But I just really want to find ways to inform people, and maybe it is like in nursing schools. And it seems like screening wouldn't even take place if there wasn't suspected use. So like where would the screening process come into place? I'm not sure if it would be like a human resources or EAP. Would it be voluntarily but I just really feel the need for screening. But what do we do with that information if there are risk factors? I do feel that the stigma of addiction in nursing and the fear of like losing your license and also other nurses, just kind of, we protect each other or talk about it, or, what is the word I'm trying to say? Like gossip, I guess, like, ooh, I think that but there's nothing that's done about that. So I don't know. I'm in the middle of my needs assessments for this population, including my own personal experience with getting caught on the job and getting fired, then getting reported to the Illinois State Board of Nursing, and then going into the monitoring program. So I'm not sure if I really have a question, but it's really like, where would the screening take place? I mean, it's a big need, and what to do with that information.
Chiquita, I just want to jump in and thank you for sharing with us. And please understand that in INSA, you have found your tribe of nurses who understand addiction. And if you're not an INSA member already, please consider doing that.
I am.
And the best wishes on your DMP. If you ever want to call me sometime, I'll DM you my phone number.
Thank you.
Mm-hmm.
Yeah, I echo Susan's words. You are a brave soldier, Chiquita. Thank you so much for, taking that vulnerability to express what you have gone through. I'm thanking you because if we think about the people on this call, I'm sure you're not the only one, who's gone through something similar or in different ways. We know from statistics that 1 in 5 individuals, so that means I think we have maybe, 20 people on the call, maybe 5 of us have a current or past mental health condition. That's a fact. In other words, mental health challenges, including the traumatic experience that may lead to them, are not so uncommon. And so when we have the stigma placed by society, self-perceived stigma around them, it becomes a barrier to addressing the fact that these are treatable. That's number one. And that seeking treatment should be normal. So your question about where would we do these screenings? I've been having conversations with my boss, I guess. He's the chief nurse officer at the psychiatric facility that I have some responsibilities. And I've been trying to push this matter of screening, and all the same reasons, confidentiality, things like gossip, just things like that keep coming up. And I said, well, what if we did it at the health fair? All the nurses have to go through a yearly health fair where they do their skills check offs. And I said, what if we just had a screening where they did some basic psychological distress screening, substance use screening, and just let them fill out the information. It's anonymous. If they have a high rate of something, it flags and it gives them a recommendation. Now, whether they take that recommendation or not is secondary, but at least being aware that, okay, I drink, I drink on every day. That's not too bad. I drink 3 drinks, maybe 3 beers, and I don't do that. But somebody could fill that in and say, I think 3 beers a night, no big deal. But when you look at some of the evidence-based screening tools like the audit, that tells a male you're at risk for risky drinking. Somebody asked the question, why did we say risky drinking levels or risky alcohol levels in our study? Tobacco use has no risk-free level. So we can't say risky tobacco use. But alcohol use does have risk-free levels, at least according to the research. Depending on who you ask the authorities, for ladies, you can have 1 drink a day, 7 days a week. So 7 drinks a week is risk-free. Anything above that puts you in the risk category. For guys, there's a little bit more liberality. We can have 2 drinks a day, and anything beyond that puts us at a risk level for health outcomes. So that's why we use that term, risky alcohol use, in the paper. But I think there are opportunities to find ways to do screening. Again, UC Davis, they are screening for depression and suicide rates and suicide ideation and risk. So they've found a way to do it. And I think we could possibly adapt that into some of our systems.
So I want to join Kathy and Dr. Okoli, and probably most people on this call, to thank you, Chiquita, for sharing your story in such a honest way that with so many people here. So I really appreciate it. And welcome to nursing. Welcome to Insta. And like Kathy, I'm glad you're joining the ranks of the DNPs. You clearly have a lot to offer. One of the things that I was struck with when I read the article, and I know I mentioned it to Surratt and Dr. Okoli when we met, was the first time I read the article, I sort of read it from a detached viewpoint. I didn't identify myself as being somebody who had any sort of traumatic experience in my work relationships. And then I read it a second time and it hit me when I started to look at the statistics and how common it was. I really had to stop and pull away and say, wait a minute, let me just reflect on my 40-year history of nursing. And so I'm thinking now about the screening part of this. If I had been given a screen, have I had any kind of traumatic experience? I really would have immediately said no, probably. I assume so. On reflection, though, and I work in substance abuse, as I think most of you do. So that means I'm working with women who have had terrible stories, including sex trafficking. And I did take those stories home at night, and they still stick with me. There are people who I worked with 20 years ago, and they still can haunt me, not to the same extent as your experience, Dr. Okoli, not where I was not sleeping for 5 years, but so not to the level reaching a PTSD diagnosis. And that's not what your article was looking at either. It wasn't looking at the PTSD diagnosis. It just really spoke to me very powerfully about just how the traumas can occur in nursing. And I know other people have talked about what happens in between shifts. And yes, that I remember those days. People weren't kind to each other all the time. In fact, I think there's even somewhere there used to be a joke about how nurses eat their own, and we laughed about it, but it wasn't funny. It wasn't funny then. It wasn't funny now. So I think the idea of thinking about the trauma, this article for me really helped me to understand trauma with lowercase t, trauma that's not post-traumatic stress disorder. Just wanted to open that part of this understanding of the situation as well.
Thank you, Dr. Schell. And to add to that, we looked at different types of trauma. And for individuals, traumatic experiences, the impact varies depending on background, history, prior experiences, cumulative traumas, right? So we didn't want to say that people who had a certain trauma were more likely to experience a certain kind of substance use. Okay, with cross-sectional analysis, it's mere association. There's no causation. And so when you looked at one of the figures, we found that people who had had prior sexual or domestic violence were more likely to also indicate tobacco use and risky alcohol use. It's an association, which one came first. It's always hard to say in that respect. So one avenue for future research is that qualitative aspect of the impact of a trauma to a person. We didn't really collect that information. And like you mentioned, Dr. Schell, when you read the article, you're thinking, well, you've had probably all nurses have had cumulative trauma, if not firsthand, secondary traumatic stress. My first experience of that was when I worked pre-nursing. I was an ICU technician, and I saw a man who was brought into the ICU because he had attempted to end his life by suicide with a shotgun, and he survived. But he didn't have half his face. And I had never witnessed that in my life. And I was responsible to care for the individual. And I still see that image. So you can imagine what other ICU nurses, ER nurses may also encounter. And there is a compartmentalization. There is a hardening that occurs, but it never really goes away. and you add that to other experiences of trauma, maybe not in the workplace, but in your life. There's a book that says that the body keeps count. We may not be conscious of these things consciously, but subconsciously they do affect us. So I think nurses, we are absolutely individuals who require, I don't want to be too strong, but we are in need of help. And if we can encourage one another when we see signs to seek help, it would go a long way in helping our workforce to be more healthy, to be more supportive of one another, and to be a workforce that really values well-being. That's really the key. We need to model what we value. Surette, I've talked a lot. Do you have, Surette, she's been a psych nurse for years as well. So Surette, do you have anything to add?
Yeah, so I went straight into psych nursing too right out of school. I'm a straight up psych nurse. I went to the same hospital as Dr. Okoli. I've had a lot of scuffles. Thankfully, have not experienced a lot of workplace trauma myself. And something that I've seen a lot with my coworkers is after that adrenaline wears off, after all that giggling and shaking wears off, there's always somebody that makes a comment that we're gonna go to Trader Joe's after work. We're gonna get a bottle of wine and we're just gonna sleep and watch Netflix, and that's it. And it's almost talked about in a joking way, it's there. We all see it, we all know it amongst our peers, but there's not a formal structure in place. And that's, I think, what a value of some kind of screening tool would be for, is we see all of this substance use amongst our peers, but how do we get them better identified so that they're connected with resources that can help them? And something that did come up was just make it more visible within the hospital. I know that there's so many different programs that at least our place of employment offers for our employees. But I think the key, again, is just destigmatization. And someone in the chat, I think it was perhaps Eric, somebody had mentioned that they themselves walked their peers to get, to kind of, disclose that they had a substance use issue, and they sought out treatments. And I think that kind of model would be awesome to have within the workplace. It's just letting our employees know that it's available. It's here for us. It's nothing you're going to be punished for. It's a health issue. It's your own private information. And the screening can occur at various different areas. One is amongst peers, kind of an informal way, but just hey, there's this program available. Do you want to perhaps take a look at it, or I can send you information about it? And the other one is, again, like Dr. Okoli mentioned, the health fairs. Substance use is a health concern. It is a behavioral health concern. So why not implement that as part of one of our screening questionnaires? It could be something very simple. Just how often on average do you drink? Do you feel like it's a concern? Does it affect your functioning or something like that? And if they are flagged, then to follow up with their healthcare providers about possible resources and treatment that they could seek out. So a lot of work to be done, but it's getting there. We're slowly getting there.
I know that the place where I work once a week, which is the outpatient facility for substance abuse, have started a regular, I think it's Tuesday and Thursday lunchtime meditation program, which I think, as I think about it, it's a wonderful way to really help people just get together and address some of the issues of just working in this environment for so long. I'm not here on Tuesdays or Thursdays, so I haven't been able to participate with it, but I think it's something that maybe it's a great idea. I have to think about expanding it to Wednesdays when I am here.
I think that's such a supportive idea, of course, within the context of meditative practices, which show evidence in reducing substance use behaviors and also other mental health conditions. They can help. But I think the idea of doing it as a group and having that support is really key, and it's important. We know when we help our clients or consumers or patients go through group therapy, we know how therapeutic that can be. I think the same principles apply to help us work through things. I know that at least in social work and in psychology, they require, if you're going to do therapy of any form while they're through school, you need to have a therapist yourself. We don't require that in nursing school, but they do require that in counseling and social work, typically. It's not a bad idea,
I did not experience that. I'm a social worker and a nurse. I did not experience that, but I graduated from school a long time ago, so that's nice that it changed. I have a client. I work with people in a company there. I work with people in Asia and Kurdistan, a lot of different countries, and I understand this is not statistically proven, but I just feel that there's a lot more empathy for workers in other countries and compared to what's expected of us in our country, even in terms of our workforce hours. I find that, but I have a lot of clients where they're on leave and they don't have to jump ropes to go on leave, and there's understanding of conditions that are not healthy and they want to make it better. I don't feel that's an experience I've personally seen here in our country. I've as a nurse, I've experienced workplace bullying a lot. There's been a lot of that going on in my place. Unfortunately, it's changed a lot, but it's still really, it's like doesn't really want to be addressed. And wellness. One of my clients I worked with in a car factory during COVID, there were so many people taking off that they took an auditorium-sized room and converted it into cubbies where they allowed people to put on headphones and listen to certain waves of different frequencies, which was proven to help relax them, which I thought was amazing. I do a lot of groups in my facility on wellness and breathing and essential oils and things like that, which I think is nice. I think it would be nice if it gets transcended over to employees as well. And I do definitely see, I have a lot of doctors that come to my facility, and I have to tell you, they brag to me about how after surgery, I was using some of the drugs that I gave, I have a lot of anesthesiologists, and they say to me immediately, there's I call it a blanket of protection. They're legally protected. Their financial resources are protected, so they won't get sued. They're not arrested. I work with a lot of, I've worked in 2 states, Florida and New York. In Florida, it was an emergency psychiatric room where we've had airplane inspectors and things come in, really scary, and we all write down what airline you work for, but there's a lot of protection and help given without stigmatizing, without fear of losing your job. I don't see that happening among nurses. I'm sorry. I don't see the same thing.
I agree with you, Susan. I think that's another avenue of our voices being heard as nurses. We need to be protected. Just like the physician groups are very strong in their ability to protect themselves. Well, nurses, we are the largest workforce out there. We're the largest healthcare workforce. So we really have a strong voice. I also do some work in Asia. My wife is actually from Taiwan, so I tend to go to Taiwan a few times. And I take some students with me. And I remember an incident, what you were sharing, Susan, reminded me of this incident. I went to a psychiatric facility, and they still have a plexiglass barrier between the patients and the nurses station. And so they were giving me a tour, and I saw that. I said, "Oh, what's that?" They said, "Oh, we got to protect ourselves." I said, "Oh, that's interesting." Said, we got rid of that years ago in my hospital. And they looked at me shocked. And they said, aren't the patients going to throw things at you? And I said, well, once you take away the wall, they have no target to throw things at. They're not throwing it at you. They're throwing it at the wall that divides you from them. And it's an allegory of culture change and the way we see things. When we bring in trauma-informed care processes, like in our hospital, Eastern State Hospital, we saw a dramatic change in the need for restraints. I know when we did it, a lot of our staff who had come from the old hospital to the new one, they were skeptical that it would work. But once we did it, it changed. We had like 40% reductions in our restraining patients. We barely even use our restraint rooms anymore. They're almost there just to show visitors, this is what we used to do. So I believe that in terms of bringing in health checks, bringing in ways to support nurses who may have substance use disorders and being able to report it and seek treatment, it can happen, but it does require culture change, and it requires time, and it requires a lot of us standing up and saying, this is what we need to support ourselves and to stay well. I almost feel like I'm speaking as the president of APNA, so promise I won't use my presidential voice much. But I really believe in this. I do believe in what I'm saying.
I appreciate your presidential voice, so you can keep it coming. It's okay with me. The chat has had some interesting things, and for whatever reason, my chat is not working, so I can't go back. So I apologize that if I should have been responding at the time. But when you talk about culture change, I'm thinking about some of the things I've read in this chat. And the one that keeps coming to my mind is somebody's talked about a breakfast of vodka with the nurses. That just doesn't even make sense to me on so many levels.
It wasn't with the nurses. I didn't go in. I found out about it because I don't drink, so they didn't. I was upset that I wasn't being invited to this group. So then one of them told me why, but it wasn't the nurses. It was the behavioral health techs. It was everyone in the facility. It wasn't just the nurses. I will tell you that we were it was in Florida, and it was a government-run facility. It looked like a prison. It was the best job I ever had. I loved it because we were a true team, except there were obviously some issues, where people felt they weren't getting support. There was a lot of alcohol among staff, not on the facility usually, but that even so. But my administrator, after someone got their skull fractured, a worker, was really there for us. I mean, I remember meeting with us the next day and saying, tell me what I can do to change things. Tell me how I can help. I've never had a boss like that. Not that my boss now is great, but I'm just saying he really wanted to help. And he had a big voice in government there. And I really have to say, it was probably the lowest paid job, but it was the most rewarding job I've ever had. I had to return back to New York, but I loved that job. It was amazing because we were a true team. You had to be, because we took people from state penitentiaries that were the people they didn't want to keep there, and they brought to our facility. So they were very violent, and they were also violent to themselves. They would come with razor blades in their mouth. It was very sad, but it was very stressful. And they did make an effort. Like, I'm impressed, like on Thanksgiving and stuff, the wives of the administrators would come and bring food and make dinners. It was a nice support center. But obviously people felt that they were very stressed out and they were using things like that. And yeah, I think the vodka morning breakfasts I was kind of shocked about, but I think that's indicative of the stress levels that were going on.
Right. Thank you. I didn't remember who had written that. So thanks for sharing a little bit about that. We have 4 minutes left, and this has been a great conversation, but I just want to make sure everybody, if there's anybody else who has anything they want to add. I know Kathy just sent some information that I think is for everybody. Bernadette Melnick recommends a focus on nurse wellness, and there's a YouTube. Thank you, Kathy, for sharing that. I'll have to try to write that down so I can, before I lose it. But again, if there's anyone who has something they want to add for Dr. Okoli or for Surratt. Sorry, I'm sharing. I'm just writing that down, Kathy. I don't mean to. Well, I want to then just take the last few minutes to thank you both for coming. Thank you for writing this article. It's shocking that we don't have more information out there with this really important connection between what's happening with substance use and what's happening for nursing in terms of trauma. So thanks for bringing that to our attention. Thanks, Kathy, for all of the things that I saw fly by, but I didn't come back to. Our next, Patrick's agreeing, I can see that one. We have the journal club every time the next journal comes out. Our next date will be, I think, the 3rd. I haven't spoken to Robert about this. I'm hoping it'll be the 3rd Wednesday in July. And we'll all have to just wait unless, Anne, you happen to know what the article is. I don't see her on at the call again. But I invite you all to come back. The conversation is always important. And the more voices we have, the better for us and the better for the practice of nursing, of course. So thank you. Thank you, Dr. Okoli. Thank you, Surratt. And a lot of people read the chats because there's a lot of thanking coming to the two of you.
Well, thank you. Thank you very much for inviting us.
And again, if anybody has anything they want to add, you have another minute. Okay. All right. Yeah. So share. I think somebody is saying, make sure we share the information for others in terms of the journal club meeting and especially in terms of your article. Is it okay, Dr. Okoli and Surratt, if other people share this article with their facilities, with their coworkers?
Absolutely. As long as it's okay with the Journal of Addiction Nursing.
Excellent. We didn't even address, I meant to suggest this, Dr. Okoli, you are teaching nurses some of the importance of trauma and addictions. Yes?
Yes. Yes.
So I know we talked about the importance of teaching students and it's occurring. Okay, then thank you to everybody.
Thank you.
See you in July.
Great article.
Great article.
Thank you.